Good afternoon, everyone, and welcome to today's program titled Trauma in the Nervous System. I'm Tom Valentino, Senior Editor at the Institute for the Advancement of Behavioral Healthcare. Today's program is sponsored by Sierra Tucson. Thank you to our sponsor and to our audience for giving us your time and attention today. Before we get started, we have a few details we'd like to go over. To submit a question for our presenter, please use the Q&A area below the slides at any time. You do not have to wait until the end of the program to ask your question. To troubleshoot technical issues, please click the Test Your Connection button below the video window to chat with support. To download a copy of the presentation, please click the link in the Resources tab to the right of your slides. Special note about CE credit. To get your CE, you must watch the program all the way through the Q&A section at the end of the presentation. At the end, do not leave the web page. The site will automatically redirect you to a survey. This must be completed in order to generate your CE certificate. For those watching in a group, please download the group submission guide in the Resources tab and follow the instructions provided. Please note, CE credit is not available for the archived webinar. It is only available for the live event on November 7, 2018. Finally, for those of you who tweet, please tweet along with us using the hashtag IABHCLiveWebinar. And at this time, it's my pleasure to introduce our speaker, Dr. James Seymour, Director of the Trauma Recovery Program for Sierra Tucson. Dr. Seymour's areas of expertise include trauma recovery, addictions, cognitive behavioral therapy, and somatic mind-body therapies. Dr. Seymour believes strongly in the resilience of the human spirit and views the role of the psychiatrist as assisting the person in removing obstacles to the natural healing and recovery process. Thank you, Dr. Seymour, for taking the time to speak with us today. And with that, the audience is yours.
Okay, thank you very much. So, welcome everybody. This is Dr. James Seymour. I'm always love to talk about these topics, so I'm glad to have a chance to talk with you guys today. So, today we're going to talk about trauma in the nervous system, but I first want to just give you a little bit about my qualifications in terms of what I know and what I don't know. So I consider myself, even though I'm the director of the program for trauma recovery at Sierra Tucson, I'm not an expert in trauma. What I have, I think, is a lot of years of experience as a psychiatrist working in a number of different settings. And I am board certified in psychiatry as well as addiction medicine. But what I'm doing is synthesizing information that I have been thinking about from a variety of people who really are experts in the field, people like Alan Shore, people like Peter Levine, people like Pat Ogden, people like Janina Fisher, people like Bessel van der Kolk, those people who are really strong in the field. And what I've done is I've synthesized information to put it together based on my experience to give us some ideas of some thought and new ways of possibly thinking about things. So a lot of the material that we cover is probably a lot of stuff that most of you already know, but I'd like you to consider what I have to say in light of what that might mean for our clinical work with patients and clients. So the four areas that we're going to cover today is we're going to cover the new perspectives that I'm thinking about. We're going to cover the Polyvagal Theory as the basis of our understanding what the rest of what we talk about is. We'll talk about the implications of the Polyvagal Theory for clinical practice, and then we'll talk about some somatic therapies, and I'll give some examples then at the end. So that's what we'll be covering today. Now, when I say new perspectives, I'd like to toss these ideas out, not that they're necessarily true, but there's ideas that I like us to think about in terms of changing maybe the way that we view things. And I think that we should no longer talk about post-traumatic stress disorder. It's really not a disorder, and I teach our residents and clients that it is a normal adaptation and response of the nervous system to psychological trauma. So I insist that although they may have interpersonal problems and although they may have a lot of symptoms, there's essentially nothing wrong with them. They're not sick, they're not ill, they're not diseased, they're not disordered, they don't need to be fixed. They need to recover from trauma, so we talk about trauma recovery rather than trauma treatment. The next thing is I want to talk about the personality disorders. We have categorical personality disorders, and I think the time has come to stop using those. I don't think we should be talking about personality disorders at all because personalities are so complicated in terms of affective regulation and temperament and those sorts of things, and yet we put people in artificial categories. So I think we should talk about maladaptive coping mechanisms to deal with a dysregulated nervous system, which is often secondary to psychological trauma and or genetic factors as well. And this is more in line with what we know about neurobiology. It gets rid of a lot of stigma, and it is hopeful and implies the capacity to change by learning new coping mechanisms as well as by better regulation of the nervous system. The next thing I want to talk about is categorical diagnosis have been used in psychiatry and mental health for a long time using the psychopathology model, which is we've tried to look at what is wrong with someone, how do we describe it, what categories it might fit into, how we can research, how we might be able to treat different disorders, and this was very, very necessary. But I think with our new knowledge, the categorical diagnoses have basically outlived their usefulness. There are such things as mental illnesses, severe mental illness like bipolar disorder and schizophrenia. There are those type of things. But what I like to think of is that everybody's problems that we have boil down to two interacting factors. And one is in regulation of the nervous system, ways to deal with and handle anxiety. And the second one is navigating interpersonal relationships. And the two are very highly linked, and that we'll go in today through the physiology of why that's true and why the poor regulation we have, the poor our interpersonal relationships. And so this gets rid of artificial categories which don't really reflect the reality of things, and I think regulation theory is a better way of going about this. Another thing on the categories, we do notice that in DSM-4, not otherwise specified was a common diagnosis, and now we have unspecified with DSM-5, and that is also a very common diagnosis, so it means our categories are not really capturing what the reality is. The other thing is I don't like the DSM-5 in regard to trauma because it still misunderstands a lot of issues. DSM-5 still separates the trauma-related diagnoses from the dissociative disorders and phenomena. It lists dissociative phenomena as separate disorders rather than symptoms, and it does not recognize a category of complex developmental trauma. And everybody in the field knows there is such thing as complex developmental trauma and how it affects our clients, but they don't have it in DSM-5. Now, ICD-9-11, I understand when it comes out, will have a category for complex developmental trauma. But I think the DSM is more focused on acute trauma symptoms rather than the variety of symptoms that can occur from early life trauma and attachment trauma, betrayal trauma, those sorts of things. So here at Sierra Tucson, we don't treat trauma. We look at it as the individual has already survived the trauma. It's over with. And so the effects of the psychological trauma are not a disease. We don't need to treat them. What we do is assist and facilitate recovery from the effects of the trauma. And I really do believe that these minor changes in language do make a difference. I do believe in language differences. For instance, we try to teach people the minor differences between saying things like, you made me feel this way, as opposed to the I statements, I feel this way when you do such and such. And those little language differences can make a big difference in terms of working with the clients and their ability to communicate with family members. Now, the reason I like regulation theory more than categorical theory at this point is it's more concise, it's more elegant, It's a simpler explanation of complex emotional and behavioral difficulties than we have through categorical diagnoses. It's completely compatible with what we know about neurobiology, attachment, evolution, and the development of the nervous system. And one of the things I think here is that we know that biology didn't make a lot of sense until Darwin came along, and then the theory of evolution and natural selection made sense of everything in biology. It could be understood from a basic level, and the complexities could be understood based on that theory. Physics are the same way, not really understood in any general way until Newton came up with his laws of motion. Now, that is a model of looking at things, and later on we learned things more like quantum theory and that sort of thing. But I would say that the polyvagal theory, which links the development of the autonomic nervous system over time to complex human behavior, is in a similar category. It is a model of neuroregulation that, if we use and understand, helps explain a lot of complex behavior down to its very basic components. Now, we're going to cover the polyvagal theory, and most of you all are familiar with this, I'm sure, but we're going to cover some aspects of it that have some clinical implications that we don't always necessarily think of. So the polyvagal theory was developed by Stephen Porges, a physiologist who was doing physiological studies on infants. And what he looked at is that there are two distinct vagal nervous systems in mammals. And the key point in the polyvagal theory is that the neuroregulation of the heart is anatomically linked to the neural control of the muscles of the face and head. Now, I'll say that again because that's the main point. The neuroregulation of the heart is anatomically and functionally linked to the neural control of the muscles of the face and head. And it is the vagus nerve complex which mediates the social engagement system. So Dr. Porges' quote is down below, and I really like that as a full quote. It links the evolution of the neuroregulation of the heart to affective experience, emotional expression, facial gestures, vocal communication, and social behavior that's responsive to the behavior of others. So that's the main point I want to make today. Now, the vagus nerve is basically the parasympathetic nervous system, which is responsible for the rest and digest. It is a cranial nerve originating in the brainstem. It is the vagus nerves are the second largest nerves in the human body. The largest are sciatic nerves going down the leg. And the vagus nerves innervate everything that I think of as our innards, our heart, our lungs, our stomach, our intestines, the other GI organs, everything that's kind of on our inside. And the interesting thing about it is that 80% of its fibers are afferent, that is, they're coming from the organs back to the brain. So all our organs through the vagal nerve talks to the brain much more than the brain talks to the body. And this has implications for why body-oriented or somatic therapies might be very helpful and effective. Now, there's two vagal pathways that run together. There's a myelinated system and an unmyelinated system. Now, myelin is the protein and fat sheath that insulates nerves. Now, older evolutionary nerves were unmyelinated, and the conduction is very slow. It's just like an uninsulated wire. The conduction is very slow. And the myelination, which is the sheath around the neurons, results in very, very fast and rapid communication and rapid propagation of the electrical impulse down. And that is what we have in mammals. We have both systems that run together. We have our older system, and then we have our newer system as well. Now, each one of them originates in a different place. Both of them are in the medulla, which is part of the brainstem, and the dorsal motor nucleus of the vagus sends out unmyelinated neurons, and it's in what's called the nucleus ambiguus, is nearby, but it is myelinated and is part of the ventral vagal complex. So dorsal meaning it's more at the back of the brainstem, and the nucleus ambiguous more at the front of the brainstem. Now, the nucleus ambiguous also includes cranial nerve 9 and 11, which innervate the tongue and the neck as well. So they're part of that same complex. Now, the ventral vagal complex includes more than just the vagus nerve. It is basically including what are called the special visceral efferents. That is, the nerves that run, cranial nerves run to our face and head. They're evolutionarily derived from the branchial arches, which are gills of fishes. And what we're looking at is cranial nerves 5, 7, 9, 10. 10 is the vagus nerve, and 11. And what these nerves regulate is chewing, sucking, swallowing, vocalizations, facial expressions, listening, guts, heart, lungs, and head turning. So the ventral vagal complex is the system of our social engagement. And I'll give you an example of how it works. My father, bless him, was a wonderful man, and he is now passed away. But when he was older and had some dementia, his hearing was good. He had nothing wrong with his hearing. But when he was under high episodes of anxiety or high sympathetic nervous system activation, the muscles that control the eardrum are changed, and they're not attuned to the sound of the human voice as they normally are. So if our ventral vagal complex and social engagement is on, our ears are tuned to the sound of the human voice, but it's not if we have high sympathetic nervous system activation. We actually are attuned to low frequencies, such as a growl. So what he would say is, I can't hear anything that you're saying. And it was true. He had nothing wrong with his hearing, but when he was anxious, he couldn't hear what we were saying. And then when he became less anxious and he was soothed, then he could hear just perfectly fine. So that's an example of how the parts of the social engagement system are affected by what's going on with the vagus nerve and the interplay between the parasympathetic and sympathetic nervous system. Now, some of our behavior, basic behavior, goes to basically approach or avoidance. And all animals and all creatures that move have these two basic behaviors. We either approach something that's safe or that's a food source, or we avoid something that's dangerous. And all our complex behaviors are just advanced areas of that approach-avoidance system. And so it's the autonomic nervous system that mediates the approach and the avoidance behavior. And there are 3 stages of development of that autonomic nervous system. The first one, and the oldest one, is the immobilization system, which goes through the dorsal nucleus of the vagus and is the dorsal vagus nerve. This results in collapse, freeze, making oneself small, trying to be quiet, and not able to be seen by any threat or predator. The second system that developed evolutionarily was the sympathetic nervous system, which is responsible for mobilization under threat. And so that allows us to use the fight or flight system to get away from threat and avoid threats that are occurring. And then in mammals and in birds, there's the development of social engagement through the ventral vagus complex. And I'm not going to say anything about birds because I really don't know much at all about bird brains. So they are very unique and interesting, but that's not what we're talking about today. Now, immobilization is mediated through the unmyelinated fibers from the dorsal motor nucleus. It results in behavioral shutdown, energy conservation, freeze reaction, imminent death, and dissociation. So the human experience of the immobilization response is a sense of behavioral shutdown, dissociation, distance, detachment from oneself, detachment from one's emotions, psychomotor retardation, difficulty with speech, depression, hopelessness, suicidal thoughts, deep shame. Those sorts of things are then mediated through this immobilization system, which is really the unmyelinated fibers from the dorsal motor nucleus of the vagus. The mobilization system is the sympathetic nervous system, which is in the spinal cord, and when we use activity, we're activating the sympathetic nervous system. So we have increased metabolic activity and action. And we can have a small degree of sympathetic nervous system action, which helps us get ready for things. Like for right now, my sympathetic nervous system is more activated than my parasympathetic because I'm speaking. For those of you who might be tired or sleepy, then your parasympathetic activity would be a little bit more than your sympathetic. So they're always in some degree of movement back and forth. Now, when it's severe, we have the fight or flight reaction and the whole hypothalamic pituitary adrenal hormonal cascade that occurs when our life is in threat. And that's the mobilization system, which is our second line of defense. Our first line of defense has become the ventral vagal complex, or the social engagement system. And this is myelinated fibers from the nucleus ambiguous. And what it does is it connects the regulation of the heart to the muscles of the head and neck and results in what we also could refer to as a vagal brake. Now, the ventral vagal complex then is responsible for social engagement and is necessary for the primary emotional need that we all have, which is connection and attachment, which stays our primary emotional need throughout our lives. Now, the vagal brake, if we look at it, it's myelinated fibers again from the ventral vagal complex. It gives us a chronic vagal tone. There's always the vagal nerve is giving us some degree of activity, and what this results in is decreased blood pressure and decreased heart rate from what would be normal based on our system if we didn't have that vagus nerve applying a little bit of a brake. So it inhibits the normal firing rate of the heart. Our normal rate would be closer to 100 to 120 as normal if we didn't have the vagal brake. Now, the interesting thing is what it does is, because it's very flexible, it allows an intermediate state between relaxed awareness, which is where we function well, and the full sympathetic nervous cascade. So some animals, like fish, they go from stillness to full sympathetic nervous system cascade, whereas we can be mildly anxious, moderately anxious, severely anxious, and modify our behavior based upon how anxious we are. And that is for how much we activate the vagal brake and how much that's in play. Now, to understand the vagal brake, we need to understand it as allowing effective social communication if it's fluid movement. And the vagal brake is also directly related to heart rate variability. It's reciprocal in that the social engagement of another person increases our vagal tone. So our vagal tone, vagal brake, increases when we are in connection with a friendly or helpful or supportive other. So attachment increases the vagal tone, and it operates in a setting when we're relatively safe. And because it can go on or off in a very graded way, we don't have an all or none phenomena. We have graded inhibition of our cardiac pacemaker, so we can regulate our heart anywhere from some degree of bradycardia all the way to a full tachycardia and sympathetic nervous system fight-flight activation. Now, what Dr. Porges did was developed an ability to measure the degree of the vagal brake through respiratory sinus arrhythmia. And that is what he used to measure the fluidity of the vagal brake, and it did it in a non-invasive way. And the increase and decrease of the heart rate is associated, we know, with the breathing cycle. It's a naturally occurring rhythm. When we breathe in, our heart rate increases. When we breathe out, our heart rate decreases. And what he found was that the higher baseline respiratory sinus arrhythmia and the higher amplitude of movement under stress is associated with higher vagal tone and smoother functioning of the vagal brake. Okay, so what does that really mean for us? And I'll give a couple examples. he found some things such as a low degree of vagal brake, respiratory sinus arrhythmia, and then one that's inflexible at 9 months was the strongest predictor of behavioral problems at age 3. It was the strongest physiological monitor that would predict behavioral problems at 3. There's also looked at a sample of people with, I call it the so-called borderline personality disorder because I don't like that diagnosis, but they had the DSM-5 criteria for personality disorder. And they showed similar sympathetic measures and the same baseline respiratory sinus arrhythmia as the controls. However, unlike other people, the continued presence of another decreased the functioning of the vagal brake and increased the tendency towards avoidance and less social engagement. So the longer that they stayed in the presence of another, they became more fearful. And we see this in that it's very difficult. There's an approach avoidance problem that's basic in people who have borderline personality disorder and related problems. So the continued presence of another reduced the RSA, whereas normal attachment would increase respiratory sinus arrhythmia and increase the functioning of the vagal brake. Now, some other data, women were studied with histories of abuse. They didn't have a diagnosis of post-traumatic stress disorder, but they had lower respiratory sinus arrhythmia at baseline, and when there was a sympathetic challenge, they had poor recovery. And also it was found that reminders of abuse lowered the respiratory sinus arrhythmia, which reduces our flexibility. And one of the things that they looked at and mediated or mitigated these findings was yoga. So yoga is directly responsible for increasing the flexibility of the vagal brake, the respiratory sinus arrhythmia, and thus is a useful thing for us to do in terms of trauma recovery. Now, again, the immobilization response is associated with what our psychological phenomena of dissociation is. The immobilization response is physiological. The dissociation response is a psychological construct of that physiological response. And so the lower that we have of the RSA, which is the decrease in the vagal brake, it increases the likelihood that we will experience the immobilization response from the unmyelinated fibers from the dorsal motor nucleus. And I'll give an example of this. Let's say I'm a young child and I'm being abused in some way by one of my parents. Well, I can't use the ventral vagal social engagement system to work through that threat because I'm being threatened by the very person or persons who should be able to provide me the secure attachment. I'm too young to use the fight or flight system because I'm too young to fight, I'm too young to flee. So automatically I will go into the last protective position, which is the immobilization response, the collapse response, or psychologically the dissociative response, so I don't feel and experience what's happening to me. And that is safety, that is helpful. However, if we're using that a lot when we're young, it becomes the default mechanism by which we deal with any anxiety later on as we get older. Even milder anxieties, which wouldn't normally result in dissociation, will result in that in people who are using that from the very beginning as their only good survival mechanism. Now, what we do know is that, like I just said there, traumatic environments decrease the flexibility of the brainstem. There's less limbic and cortical control of the brainstem, and so there's decreased opportunity for the development and fluid functioning of the social engagement system. So there's an impaired capacity to be soothed by others when we've had early life traumatic environments. And we all see this in our clinical work. Now, what does this mean clinically? And here's my view on it, and I'd like to think about this idea. And that is, the goal of all assisted facilitation of recovery from the effects of psychological trauma is to improve functioning and increase the quality of life and adaptive coping behavior. That's what we want to really do, is increase the quality of life by whatever means helps us to do that. And so what I would say is that the therapeutic interventions that are most likely to help achieve those goals are any interventions that engage, recruit, utilize, and expand the capacity of the social engagement system. So what my hypothesis is that therapeutic interventions that increase the capacity of the social engagement system are helpful. Those that do not are not helpful in helping people recover from the effects of psychological trauma. Now, so the clinical implications is that you can use a bottom-up approach in addition to our usual top-down approaches to helping people deal with anxiety. So a bottom-up approach means engaging the autonomic nervous system directly when possible. Most of our psychotherapies deal with the cortex in terms of our thinking and changing our thinking processes, which are very good and useful. The limbic system helping evaluate and understand our feelings, but do not change the autonomic nervous system, which is responsible for many of the symptoms that we see in people with post-traumatic stress disorder and related problems. So in trauma recovery, a lot of face-to-face verbal interactions, which is our usual thing that we do, they're less likely to mobilize the ventral vagal complex, but instead mobilize the sympathetic nervous system, which is a defensive system. So it's not necessarily always the best mode of recovery to be in constant face-to-face typical psychotherapeutic interactions, although they're extremely helpful and necessary, but they can mobilize the wrong system. So this goes along with what we know about consistent findings and all studies that have shown what are the benefits of psychotherapy and what makes it work and what makes it not work. And as we all know, it's the non-specific factors. It's not specifically the type of therapy that we use or the type of interventions, but it's the quality of the therapeutic relationship that's the most important factor in assisted healing. The second thing is that we must have positive regard for the client and expectation of possible change. That's very important as well. And the other thing is that what helps foster regulation capacities is repeated attachment disruption, empathic disruption, and repair. And this is a big difference between those of us who have come from better environments and those of us who have come from traumatic environments, because there's always parental attachment disruption and empathic failures, but there's episodes and opportunity for repair. And many of our clients with histories of significant trauma and early life trauma have the attachment disruption, they have the empathic failures, but there's no opportunity to repair, to increase the regulation capacities. So for us, it means that some things are useful at times to use. I'm sorry, I should not have said that, I should not use that tone of voice, or I misunderstood, can be very helpful because our clients are not necessarily used to hearing somebody try to repair a relationship by acknowledging a fault in themselves rather than just blaming the other. So I think when it's appropriate, these things are very, very useful to be able to do, is to use those when it's appropriate and we know we've had an empathic failure or we've simply misjudged the client or whatever. Now, the other thing that makes a difference, and this has been shown in many studies, is that a feature of a successful therapy session in terms of treatment of post-traumatic stress disorder is a pendulation from some relative parasympathetic predominant state to a moderate rise in the sympathetic state, staying within a window of tolerance, of course, followed by a return to a relative parasympathetic resting state. So it's had that rise in anxiety and decrease in anxiety and settling during the course of the session. That's much more helpful than a session that's emotionally flat or a session that results in increased nervous system activation that does not stay in the window of tolerance. So a common problem that we have when we're working with our clients is We often start our techniques when the sympathetic nervous system is more activated than the parasympathetic system. In other words, they're not in ventral vagal complex predominance. And increasing the sympathetic stimulation past the window of tolerance doesn't then allow the parasympathetic pendulation to complete, and this results in people doing worse in our therapy sessions than getting better in our therapy sessions. So my view of things is, we always say it must get worse before it gets better. Well, my hypothesis is that that's not true. That how do we know if we made a mistake in a therapy session in terms of addressing the autonomic nervous system? And those things are that the client feels worse after the session. And I'm talking about immediately after the session where our clients are tired, they're overwhelmed at times, they feel like they've gone through the ringer. Those types of things are completely normal. But in between sessions, if they feel worse or their functioning goes down, what I would say is we've done something that is wrong. We've activated the sympathetic nervous system without allowing parasympathetic state to resolve. So what are some of the modalities we can use that are somatic modalities that can directly alter the autonomic nervous system? We have breathing exercises, which we all teach, mindfulness, which we teach, distress skills management, which we have in dialectical behavioral therapy, grounding, which we teach in many areas, equine therapy, yoga, dance and movement are very, very effective. We also have music. Music is very soothing for a number of people. We know that group support in therapy often helps more than individual therapy in traumatized individuals. Games and having fun and activating the play system is useful. Touch is very helpful, so things like massage and somatoemotional release and those things that involve some touch of the body. Acupuncture can be extremely helpful. Drumming, which is a social engagement activity, art, and then some of the more formal therapies like EMDR, somatic experiencing, and sensorimotor psychotherapy can be very useful as far as directly addressing the autonomic nervous system in our work with our clients. Now, we talk about bottom-up processing, and what that really is, it's the idea of that bottom-up processing is we look from the trees to see the forest. It uses inductive reasoning. That is, we're looking at small things and gathering a bigger picture from that. And so it's what I would call small chunk processing. So an example of the inductive reasoning would be those who watch the old TV show Columbo. He always knew who the person was that had been the villain, but he had to find the little pieces to put that together. And so he used actually deductive reasoning because he had the answer first. He had the forest first, and then he put the trees. Whereas Sherlock Holmes, when they often talk about the deduction, he used inductive reasoning. He found little pieces and put them together in small chunk processing to find out who the villain was. But the idea is that we have small changes can result in big changes in the nervous system in terms of what we do clinically with people. So both somatic experiencing and sensorimotor psychotherapy, which are very similar, are bottom-up processing techniques. They are basically, in some ways, can think of as just somatic mindfulness. Also, we would say the narrative or the story is not in the autobiographical memory narrative, but the narrative is in the body. We can do this trauma recovery assistance without knowing the whole verbal story. And they do not require repetition of the traumatic events. What we do is focus on expanding the capacity of the ventral vagal complex, and we use very carefully titration and the window of tolerance in our work. Now, I'll give a couple examples, and then after the examples, we'll have time for questions. I want to talk a little bit about the alexithymic man. This was a man that came into Sierra Tucson, and he was middle-aged and quite depressed. He'd had chronic depression all his life that had not really responded well to medication treatments, or he had side effects, and he'd gotten to the point where he didn't really want for a while to try any more medication trials. but his basic way of understanding and seeing himself was that he had no feelings at all. Nothing. He could not identify any feeling state at all. So in working with him, what I did was try to find something that he could tap into that was positive for him. And we had one session where we were not able to tap into anything at all. Everything that we tapped into or tried to tap into had some negative connotation to it. But in the second session, he was able to realize that he was a good teacher. He was a teacher of languages, and he really thought to himself, that's one thing I've done well. So rather than talk about that anymore, what we did was focus on the body and the autonomic nervous system to allow him to have the physiological sensation of doing well. And it started with him in a little tiny bit of warmth right in the center of his heart. And by paying attention and mindfully observing that, it expanded over time throughout the rest of his system so that he had a sense of actual genuine warmness, an emotion that he had not experienced in quite some time. And this was very useful in his therapy because when he would come back for sessions and there would be some degree of depressive return, we could always remind him that he had the capacity for those feelings because of the experience that he had, and that gave him a great sense of hope. Now I'll talk about another example. This one I don't have listed there, but it's who I call the heart attack woman. I had a middle-aged woman that came in, and she had had a heart attack, and she for 2 years was very anxious. She had 2 episodes where she had returned to the emergency room fearing that she had a heart attack. She did not. And what she had done was she had cut off all sexual and physical relationship with her husband because of fearing of having another attack if she was involved in sexual activity or if her heart rate increased. She felt very guilty about this, and this was a cause of great distress for her because she knew it was a problem for her husband and would be affecting their marriage over time, yet she simply could not approach that without a heart rate increasing and then fearing she would have another heart attack. So what we did was we used a titration technique, which is very similar in some ways to desensitization. And what I asked her to do was just when she thought about her husband, what she noticed in her body. And what she noticed was a rise in anxiety, a rise in heart rate, some degree of tension throughout her chest. Now what she did was she mindfully watched this. And during the mindful watchness of it, it came down on itself spontaneously to a point of feeling relaxed again. So we step by step increased the view and her exposure in her mind to various contact with her husband until she had a high level of anxiety that rose up and stayed and did not go away. In other therapies, I would be worried about this and see if we could bring things down. But using the techniques of somatic experiencing and sensory motor psychotherapy, what I did was check in with her to make sure that she was doing okay, that she wasn't frightened. If she was frightened, we would need to do something about it. She said she could hang with it. And so I quietly sat with her for 10 minutes while she processed and watched and followed and mindfully tracked where that anxiety went. So by a process of mindfully tracking for 10 minutes, which means I had to be silent for 10 minutes and yet let her know I was still in the room, it finally rose up and then went back naturally to a normal parasympathetic state. As soon as that happened, she started crying, and she realized at that moment that she could have contact and sexual contact with her husband, and it was going to be a new beginning for her. And we didn't do much talking. Much of the session was just me being quiet while she did the tracking. That's an example of then working directly through the autonomic nervous system. I have another example, and that is the demeaned woman. Everybody, when we're working in this field, we have either women or men who are demeaned by their partner. They'll put down, criticize. The partner's not really seriously abusive, but is certainly negative and negativistic and results in some degree of learned helplessness and chronic depression. So this woman came in, she was middle-aged, and she was chronically depressed, and there was problems. She's never able to stand up to her husband in terms of his criticism. And what she began to recognize was that she was angry with him, and quite angry with him. So what we did, rather than talk more about the anger, we allowed her to notice the sensation of anger in her system and then mindfully track it to see what would happen to it. And it did it in a similar way to the heart attack woman. Anxiety and tension would rise, and anger would rise and build up, and then it would begin to decrease on its own. And so that is working through the body, and what it did was it changed her thinking, because when the session ended, she started changing and saying, maybe my perspective is a little bit off. Maybe what I need to be doing is sticking up for myself a little bit more, because my husband is not that bad. Maybe I've contributed to this problem as well. And so she had some hope as far as making some change. We didn't role play. We didn't do boundary setting. We didn't do those typical things we would do in a psychotherapy session, but we simply had her track the anger, watch what happened to it, and as it went down spontaneously, it changed her thoughts and her emotions. So this is an example of bottom-up processing, where working with the autonomic nervous system can change our thoughts and feelings rather than the other way around. I think that's all I have to say right now, and then we'll be opening it up for questions at this time.
All right. Thanks a lot, Dr. Seymour. That was a very informative presentation. We've had some questions coming in from our audience. However, we would like to remind everyone that you can use the Q&A area below the slides to submit a question at any time. And also, to download a copy of the slides, please click the Resources tab to the right of the presentation window. Let's get into some questions that we've gotten so far from our audience. All right, this one came in early. Audience member says, I have heard that trauma responses can mimic bipolar symptoms and therefore can be misdiagnosed. Is that accurate, Dr. Seymour? And is that something that you can comment on?
I think it's very accurate, and one of the ways that I have found after 35 years of doing this, to my dismay, when someone first meets with me, I cannot tell the difference between moderate hypomania, severe trauma dysregulation, or severe attention deficit hyperactivity disorder. They all look the same to me, or very, very similar. And if we look at the DSM-5 criteria, they are very, very similar criteria. I simply cannot tell the difference. And I don't think I'm stupid, but after all this time, it's somewhat my dismay that I've not been able to figure out how to make that judgment. What I have to do is see people on several occasions, and I have the advantage of seeing people operate in a community, so we can begin to sort out how much of their nervous system dysregulation is just due to trauma and how much of it may be due to a genuine bipolar disorder. I think a number of people are misdiagnosed with bipolar II disorder because what the clinician is seeing is the person moving in and out of the window of tolerance to where they have high sympathetic nervous system activation with anxiety, irritability, anger, nightmares, increased agitation, and then drop into a severe parasympathetic state, the dorsal vagal state, where they have freeze, depression, lack of ability to accomplish tasks, those sorts of things. So if you just look at those ups and downs, you might end up mistakenly diagnose it as a bipolar II disorder when what we're looking at is trauma dysregulation. Now, what complicates things is just because you have one doesn't mean you can't have the others. So we have some that have severe ADHD, hypomania, and trauma dysregulation, so it's often very difficult to make the diagnosis. And this is why I think we see many people who have come in and they've had various diagnoses over time because those pictures are very, very hard to sort out. But I'm always looking, when I see someone that looks like they might be bipolar II, I'm always looking for, do they have a history of significant trauma?
Okay. Let's see here. Next question. Can you elaborate on the use of yoga in therapy, specifically with trauma patients?
Yes. In fact, I've listed a reference there on the last slide, which you'll see the second reference, which is a book, Overcoming Trauma Through Yoga, Reclaiming Your Body. The studies done by Stephen Porges showed that yoga did increase the capacity of the ventral vagal nervous system through increasing the respiratory sinus arrhythmia. And so therefore, it was one of those activities that expanded and used the capacity of the ventral vagal system by the activation of the motor activity, as well as the attachment in the yoga groups, as well as the movement of the body, which moves people out of a freeze or frozen or stuck position. So I think yoga has been demonstrated in studies to be very helpful in people with post-traumatic stress disorder and related problems.
Okay. How do you encourage or treat clients who are suffering from bipolar or PTSD when they are still surrounded by triggering events with their environment, such as family and friends?
That's a very difficult and complicated question, because one of the things we know is that for successful trauma recovery, we must have safety, both safety within the therapeutic environment and safety in the home environment. And a lot of people are not in that situation. They're going back to very complex family dynamics or sometimes abusive relationships. And the hard thing to do is to work with somebody in that setting, because you know that a lot of the symptoms are going to occur as soon as they go back to that setting. So what I try to do is focus on helping people set boundaries, but embody boundaries rather than just role play. And so there's a direct link between the body and the mind. There's no difference between the brain and the mind and the body and the mind. So that each one of our emotions and each one of our activities has assigned with it a certain body sensation or movement, so that when we are happy, we automatically smile, and we know a smile is different from a fake smile. When we're ashamed, we automatically look down and avert our eyes. That's just what we do when we're ashamed. So if we set effective boundaries, there's actually a body position where you move into, where your hands are up in the stop sign, like a position where the body is saying stop. And what I found is if people can do that and feel the strength of their body doing that, they're able to set better boundaries than if they're just sitting still, or if they're not, or they're just trying some words that they've used in terms of role playing. So people, if they can embody and feel that strength, then they're better able to set appropriate boundaries without having to be taught exactly what to say, because we never know exactly what the circumstances are. So that's, I think, the best I can answer that question, but it's very complex and difficult for all of us.
Okay. Can you share some other concrete examples of techniques to use in sessions? You gave some examples of mindful awareness of body sensations. Are there other techniques to use in session?
Yes, there are other techniques. And one of the things that you can do is you can fluctuate between, say, a body sensation and the image that comes along with that. Sometimes we'll have a body sensation and we'll have a feeling or emotion that goes with it. So we have another track, or we have another channel to look at, which is the emotion and how it connects with the body and interplay between them. Or someone may see an image that is related to early childhood or other types, which is an example of, say, maybe one of the things that has resulted in their trauma. So they're able to track their sensations to that image and be able to see how those are linked. Sometimes we have work in meaning in terms of the typical questions. Well, if this happens, what does that mean to you? And my two most common questions that I ask over and over again are to increase mindfulness. And one question is, what do you notice? I'm always asking, something happened, I just noticed something happened, what did you notice? The other question is, what is that like for you? So if somebody comes in and tells me that they had this experience at home, I don't assume that it was a positive or negative experience. I ask them, what was that experience like for them? And then they describe the situation. It could be positive, it could be negative, and then we get the body response to that situation and what they notice it as their body shifts. So get by with a lot of therapy sessions with just those two simple questions, and they're designed to allow someone and basically force someone to use mindfulness, because you can't answer that question, what do you notice, without using the noticing brain, or what was that like for you, without stepping back and being mindful of your behavior. So those are two of the common things that I will use as techniques.
All right. This member of our audience says, I work in a drop-in center that supports youth in crisis. Are there any suggestions for supporting youth in that 13 to 20 age range? They work with an average of 40 each night in a shared setting who are frequently experiencing a trauma response. However, they're not willing to engage in grounding strategies to move from the trauma response.
That's difficult, and I'm not an expert in that area because I don't work with children and adolescents. But what I found in general is you can activate, you don't have to do anything but activate the ventral vagal system. And the best way to do that, I think, for most people is just to be quiet and listen to what they have to say. Or if they're very quiet, you can comment on some things and ask them questions about things that may be positive in your life, which may be very minor things such as, those are nice shoes. Where did you get those? Or those look like fancy sneakers. Do you like those sneakers? And then listen to what they have to say. You're activating the ventral vagal system through social engagement, and therefore you're going to have some decrease in anxiety, even if you never get to any content or specific grounding skills. So that's what I would say, but I'm not used to dealing with adolescents or children, so it has to be taken with a grain of salt.
All right. I think that's actually going to do it for the questions for today. A lot of great questions that came in. Thank you, everyone, for contributing. We do have some final instructions regarding CE credit before we let you get going today. Please do not leave this page. Continue to stay on the platform, and the site will automatically redirect you to a survey. And this survey must be completed in order to generate your CE certificate. For those watching in a group, as a reminder, please download the group submission guide in the Resources tab to the right of the slides and follow the instructions provided. Please note CE credit is not available for the archived webinar. It is only available for the live event on November 7th. I would like to thank Dr. James Seymour once again for an excellent presentation. I'd also like to thank our sponsor, Sierra Tucson, for making today's program possible. And finally, thank you again to those of you in our audience for participating today. We hope you'll join us in the future for another IABHC webinar. This concludes today's